Assalamu alaikum wa rahmatullahi wa barakatuh. Our subject today is about screening and management of diabetes in pregnancy. The materials that I used for this subject are as follow: the Pregnancy, Childbirth and Postpartum Management Guideline 2022, and also from Diabetes Mellitus, National Clinical Management Guidelines 2021. I would like to thank the diabetologist department in Barka Polyclinic who approved this work, especially Dr. Leila, the head of diabetologist clinic in Barka Polyclinic. So the key management, why we are focusing on the management of diabetes in pregnancy? Because they found that diabetes is increasing in pregnancy, especially because increased obesity. So there's increased risk of diabetes in women. And because the complication that can happen to the mother and to the baby. For example, miscarriage, increase in pregnant with diabetes, increased risk of congenital anomalies, especially in type 1 or type 2 diabetes mellitus. Also increased risk of preeclampsia and increased liquor amount, hydromias. Also fetal macrosomia, especially in gestational diabetes mellitus. And as a consequences, there is increased risk of cesarean because, for example, in insulin dependent diabetes or type 1 or type 2, mostly they will be referred at 36 for induction of delivery. Sometimes there's fail for induction, sometimes there's big baby, so there's increased risk of cesarean section. Also, sometimes there is IUGR, increased risk of fetal organomegaly, hepatomegaly, and cardiomegaly, increased risk of birth trauma, increased perinatal mortality, and neonatal respiratory problems. Also, for the neonate, there's increased the risk of metabolic complications like hypoglycemia, hyperbilirubinemia, hypocalcemia, and development of obesity and diabetes during childhood. So, how we will do the screening for gestational diabetes mellitus? Of course, for any women at booking, we will do fasting blood sugar or random blood sugar. But some women, we need to do the assessment for the risk for developing gestational diabetes. What are the risks? If the body mass index equal or more than 30, if there's past history of gestational diabetes, first degree relative with diabetes, previous history of macrosomia, baby weight more or equal 4 kilogram, history of previous unexplained intrauterine fetal death, women with polycystic ovary, and if there is glycosylated hemoglobin more than equal or more than 5.7 or impaired fasting glucose or impaired glucose tolerance on a previous diabetic screening test, and of course, clinical condition like increased insulin resistance, like example, severe obesity, and if there is acanthosis nigricans. So these risk factors we must ask at the booking to see if the patient is high risk or low risk for developing gestational diabetic. This chart is very important and need to be available in every office. So all pregnant women at registration either will do fasting blood sugar or random blood sugar. So if fasting blood sugar less than 5.1 or random blood sugar less than 7, so if she is low risk factor, we'll do OGTT at 22, 24. But if she is high risk factor, as we say here, these are the risk factor, this point. In this case, what we will do OGTT. So if OGTT, fasting blood sugar more or equal 5.1, more or equal, or 2 hour more than or equal 8.5, in this case, consider GDM, finished. In the GDM, what we will do, we'll advise for dietitians, strict diet, blood sugar profile after 2 weeks. But if we do OGTT and the level come normal, the cutoff for OGTT 5.1, 8.5. So if fasting blood sugar less than 5.1 or less than 8.5. In this case, we will repeat OGTT at 22, 24 weeks of gestation. But if from the beginning, from the first visit, the fasting blood sugar 5.1 up to the 6.9, immediately consider this GDM. We will not give her glucose. Again, if normal fasting blood sugar at normal random blood sugar, we'll see low risk factor, give her appointment at 22, 24 for OGTT. But if high risk factor, we will do OGTT. If it's come normal, again, repeat OGTT 22, 24. But if fasting blood sugar equal or more 5.1 or 2 hour equal or more than 8.5, this is GDM. But from the first time, if we do fasting blood sugar 5.1, and I know this patient, she is a high risk, that's no need to give her glucose at all. If 5.1, whether low risk or high risk or whatever, consider GDM up to 6.9. So here GDM, so refer to dietitian, strict dietetic diet, and then you will do blood sugar profile. And of course, if two blood glucose value are abnormal, you can start oral hypoglycemic medication, metformin. Always we start with 2 tablets. First 3-5 days, you can give OD, but please, the minimum dose is 2 tablets, not 1 tablet. According to this guideline, I will show you. Okay, so refer to dietitian and follow blood glucose profile by obstetrician, family physician, whoever in the clinic there responsible to follow up this woman. And if uncontrolled, of course, means you will start with 2 tablets and increase stepwise up to 2,500. If you give, for example, the patient 2 tablet, 1 tablet, the maximum 2,500 milligram. So in this case, consider uncontrolled, refer her to the diabetologist. If fasting blood sugar more than 7 or random blood sugar more than 11 at booking, immediately this is considered as over-diabetic. In this case, the treatment of over-diabetic as pre-existing diabetes. Here you will refer to the diabetologist, and it will be multidisciplinary team between the obstetrician and the diabetologist. Of course, dietitian will play a big role in the management of such patient. So again, if normal, you will divide it either low risk or high risk. If it is come normal, also repeat at 22. If it is high risk and come abnormal, consider GDM. If from the beginning, the fasting blood sugar 5.1 to 6.9, consider GDM. You will refer dietitian, strict diabetic diet, the blood sugar profile after 2 weeks, and you will review the blood sugar. But if the fasting blood sugar more than 7 or random blood sugar more than 11, in this case, as we say, in this case, consider as over-diabetic. The management is, and we consider the patient as pre-exist diabetic. So in this case, I will do glycosylated hemoglobin. And of course, can be entered with booking investigation. I will do TSH because we say we will treat the over diabetic as pre-existing diabetic. So again, what are the type of diabetes? Either diabetic detected during pregnancy, called gestational diabetic, or over diabetic, which is diagnosis of over diabetic can be made in women who made any of these with the fasting blood sugar more than 7, or random blood sugar more than 11, or glycosylated more or equal 6.5. In ordinary people, glycosylated hemoglobin more or equal 7, but in pregnant women, glycosylated hemoglobin to consider as over diabetic is more or equal 6.5. And as I say, over diabetes in pregnancy should be managed as pre-existing diabetes. What I mean here, these are what we will do. First of all, we will do glycosylated hemoglobin to know the control for the last 3 months. We will do liver function test, renal function test. We will do TSH level for this pregnant women who diagnosed as over diabetic. Of course, it will be multidisciplinary team, dietitian, obstetrician, and diabetologist. These are the checklists for a pre-existing diabetic. The preconception glycosylated less than 7. So if there's any woman with infertility, glycosylated more than 7, advise her for glycemic control and tell her that when the glycosylated is less than 7, will be low and less risk for congenital anomaly, for miscarriage, for eclampsia, and other complication of pregnancy with diabetes. And also will shift multiple daily insulin in patient on premixed insulin. And if she is on any antihypertensive medication, the ACE or ARBs should be converted to labetalol or methyl-dopa. We'll give folic acid, 5 milligram, and continue till breastfeeding. And of course, if she is on ACE or ARBs or statin, should be all stopped. And also, we measurement of TSH before conception is advised. But if you diagnose over diabetic during pregnancy, we can do the TSH on the same blood collection during booking investigation. So again, for antenatal assessment and care, of course, we say we will do ultrasound, right or not, for any patient at booking. We will do assess the patient, if gestational or overt, whatever, we will do booking. And this is to know 11 to 14, to know the gestational age. It's very important in order to decide the time of delivery. And see if there is any anencephaly during this period, because if she is uncontrolled diabetes, there is risk of congenital anomaly. So it's very important at 11, 14 week for dating scan and to see if there's anencephaly or some structural malformation that can be picked up at first trimester. Then we'll do a novel scan at 18 to 20. It's very important to see the spine and the heart. And very important to see four chamber, outflow tract, and 3 vessel view. This is very important. Then we say we will do 2 scan. What about from 28? From 28, it's important also to assess the patient first by staff nurse to see if there is any larger than date or smaller than date, because we say for diabetic there's risk for macrosomia or intrauterine growth retardation. So from 28, we can do also scan to see the growth. If normal, we can do another scan at 32 and 36. So we'll do like a growth scan every 4 weeks, because there is risk for macrosomia, risk for hydromnia, risk for IUGR, if you remember from the beginning of this lecture. And also it's very important to know the weight of the baby, and if there's any complication, there's polyhydramnia, we can inform the diabetologist, or if there's macrosomia, for example, at 32, we can refer to the secondary hospital according to the protocol for any macrosomia to refer to the secondary institute. And of course, for any case, if we diagnosed at early pregnancy, whether GDM or pre-existing diabetes, we'll start in aspirin, because these patients are at risk for preeclampsia, as we said from the beginning of the lecture. So we'll give 75 to 150. The update is now 75 milligram up to 150 milligram from 12 week of gestation until 36. Before they are stopping at 34, then they say until delivery. The update is now 75 to 150 OD from 12 week until 36 week. And it's preferred to tell the patient to take the aspirin after dinner before sleep. Again, we say we give folic acid for any pregnant women, not only diabetic, 3 months prior to conception and continue until breastfeeding. This is according to the last guideline. And all pregnant women at risk of gestational diabetic and those with diabetes should be given individualized medical nutrition therapy. Will be by a dietitian. Include carbohydrate control meals and monitor for gestational weight gain. And we will encourage the women with gestational diabetic to eat 3 meals with 2 or more snacks per day. Option of the treatment, either it is medical nutrition therapy, and most of the patient will advise them strict diabetic diet and walking 30 minutes. Most of the patient will come normal, but many of them, they are not strict diabetic diet. The counseling is the most important part for gestational diabetes mellitus. Sometimes if there's no response, we can add metformin, and as we say, metformin, the initial dose is BID. We can give first 3 days, 5 days OD, then increases BID. Or sometimes if there's no response to 2,500 milligrams of metformin, we will refer to diabetologist to start insulin. Again, women with pre-existing diabetes should have ultrasound scan for dating, structural anatomy, and growth. We say this, we say at booking, at 12 to 14, at 18 to 20, and then from 28 to 36, you can do at 28. If everything is normal, you can do after that 32, and everything normal at 36. But if you find IUGR, of course, in this will be different. You might need more frequent ultrasound. So, diving on mode of delivery in pre-existing diabetes and gestational diabetes should be individualized. So, any patient on metformin, everyone know, or on insulin, we should refer at 36 to secondary hospital. For gestational diabetes, can wait until 40 weeks. So, the screening is either by fasting blood sugar at booking, or OGTT at booking for high risk, or OGTT at 22, 24. There is no other screening method, only by fasting blood sugar, OGTT. For BSP is not screening method. It's for follow-up. Blood sugar profile is for follow-up. So how you diagnose GDM? We say fasting blood sugar equal or more 5.1, or do our equal or more than 8.5. Okay, what about blood sugar profile or self-monitoring blood glucose? Should be done after diabetic diet. We never tell the patient to do BSP without diabetic diet. Always advise for strict diabetic diet, refer the dietitian, then we'll do blood sugar profile. And preprandial must be less or equal 5.3, and 2 hour postprandial less or equal 6.5. Always we tell the patient the correct way, because I have so many patients, they are doing after 1 hour, sometimes 1 hour and 30 minutes. We'll tell them it must be 2 hours, and to write for full 2 days blood sugar profile. What about glycosylated hemoglobin? Glycosylated hemoglobin, as we say, should be done only if at booking and fasting blood sugar more or equal of 7, or random blood sugar more or equal 11. That's mean we diagnose this patient as over-diabetic. In this way, we will do only the glycosylated in this case only if fasting blood sugar more than 7, or random blood sugar more than 11 equal or more 11. That means the case is diagnosed as over. In order to more diagnosis, this is over diabetic, to know how much she is controlled for the last 3 months. And again, metformin can be initiated at dose of 500 milligrams twice daily. This is copy paste from the protocol, and increased up to 2.5 grams per day. If de-arrange BSP, we increase over 3 to 5 days, both to reduce GIT and to permit identification of the minimum dose required for adequate glycemic control. So I just want to emphasize on this point. When you will do BSP, please ask the patient if you find someone to reading, because many patients, when we take history, she will tell you, yes, I felt hungry and I drink little orange juice, or I went outside and I just eat little something contain carbohydrate, or I drink milk like this, or Nescafe. So we focus on the history because most of them, the BSP will come normal after strict diabetic diet. So what about postnatal? All women with a previous GDM should undergo oral glucose tolerance test 6 to 12. So anyone, she has a previous GDM, will do OGTT. If more than 7, this is diabetic. Refer to the GB for further investigation and to refer diabetologist. And if 2 hour more or equal 11, the same thing. So we'll do OGDT postnatal for any patient with previous GDM. If fasting blood sugar more or equal 7, or random blood sugar more or equal 11, this is diabetes. What about impaired fasting? Impaired fasting is from 5.5. 5.5, consider impaired fasting. In this case, up to 6.9. And impaired glucose tolerance if 2 hour, 7.8 to 11. So here we'll take the level of normal women, not the pregnant women, because if you remember OGDT for pregnant women is 5.1 and 2 hour 8.5, but here 5.5 up to 6.9, and here impaired glucose tolerance 2 hour 7.8 to 11. So some point regarding the OGDT also postnatal. If there is impaired glucose tolerance test, of course we will counsel the patient, send the patient to the GB and dietitian to counsel her about important about diabetic diet, and should be follow up yearly if she has impaired glucose tolerance test. I mean the level for fasting 5.5 up to 6.9, or 2 hours 7.8 up to 11. In this case, we said we will do annual. It should have annual assessment. But if the level come normal, what is the normal means? Fasting blood sugar less than uh, uh, less than 5.5 and do our less than 7.8. In this case, we will tell the patient also we will do counseling because she has previous GDM. There is risk for developing GDM in subsequent pregnancy and type 2. So we will do reassessment of glycemic status every 2 years. So for any patient postnatal, we will do OGDT at 6 and 12 weeks. If more than 7, fasting blood sugar and random blood sugar more than 11, finished. This is diabetic. Refer to GB, the GB will refer to dietitian and diabetologist clinic. But if impaired fasting, the level is 5.5 to 6.9. Or 2 hours 7.8 to 11. In this way, we'll counsel her about strict diabetic diet, importance of diabetic diet and lifestyle modification, and we will tell her there's risk to develop type 2 diabetes, and we will do annual if there is impaired fasting. But if it's come normal, the OGDT means the level less than 5.5 and the 2 hour less than 7.8. In this way, will be follow up every 2 years. Some important point about oral glucose tolerance test is very important. As we say, we will do it 22, 24. And it's clear now. Of course, we do not need to instruct the women to prepare. We will not tell her, you will do we'll give you glucose, you will drink glucose. So no need to prepare. Let her eat whatever she was eating before. Never ever need to instruct the woman to prepare or change her diet before the test. Like we'll tell her low carbohydrate in 3 days before the test is not recommended. The women need to fast at least 8 to 10 hours. So we'll ask her when last time you eat. and advise her not to eat or drink anything except she can sips of water. We will collect venous sample for fasting blood sugar and immediately we'll give her the glucose. And the level is 75 gram of anhydrase or 82 of glucose monohydrate. And we'll ask her to drink it within 3 to 5 minutes. I found that some patients that they are drinking within second, and this is wrong. Some patients they are drinking like more than 5 minutes, also wrong. It's mentioned here within 3 to 5 minutes. And then we'll collect the second sample after 2 hours. And here it's also very important, the women must stay in the clinic for 2 hours and should not eat or drink or do any exercise during these 2 hours. Because many women, they say, they ask permission to leave during this 2 hours. We should inform them that they must stay in the clinic because if they go, for example, to the mall or any place, this is considered type of exercise. So this is very important point about the OGTT. So this is according to the guideline, and I hope it is clear. Just to focus on few points, that metformin is always the initial dose is 2 tablets. There's no such thing to give only OD. BSB the patient must be fasting. The BSB must be on strict diabetic diet and seen before blood sugar profile by dietitian. For OGTE, no need to instruct the woman to prepare herself. And for glycosylated hemoglobin is to be done only if fasting blood sugar more than 7 or random blood sugar more than 11 at booking. No need to do glycosylated if the arranged BSP. And this information approved by the diabetologist clinic. Really thanks, appreciate their input. And thank you very much for everyone. If anyone has any question, can ask or write in this feedback. And again, thank you very much for your time.